Welcome everyone. This is Didier Dietschy speaking from Geneva. I'm very happy today to welcome you all to this program on TwoSwear, dedicated to the interceptive and ultra-conservative strategies. We had a first part related to diagnosis, treatment of risk factors, and implementation in modern strategies. Today is the second part, which will be dedicated to direct interceptive treatment strategies and clinical protocols. So I will go through detailed step-by-step about how I manage such treatments. And in the part 3, which will happen soon, I will be discussing indirect and hybrid treatment strategies and clinical protocols. Part 1 to 3 will create a global understanding and to also provide relatively detailed protocols about how to apply those different strategies. I remember you from the first part that we have preventive strategies, interceptive strategies, and restorative strategies, which are to be applied for more complex cases. So let's go through now the overall treatment strategy for interceptive therapy. Somehow it also applies to more complex cases, but that will be for the part 3. I presented in part 1 literature review, which was published in 2014, about the possible consensus in regard to how to treat TwoSwear cases, which was rather inconclusive in regard to the main treatment steps. A more recent publication has reported the conclusions of a European consensus meeting. And in fact, if you go in details through this article, and especially if you read in between the lines, you will realize that at the end, some people, they prefer to go indirect or CAD/CAM, and they pretty much do everything with indirect and CAD/CAM technology. And some others, they do a lot more direct. But in fact, the consensus is not so obvious in regards to the technique, the clinical protocol, and the choice of materials. The only thing on what everybody agrees is that we should be as conservative as possible. But that's pretty much the only conclusion of this article. If I summarize really let's say, the different ideas and concepts presented in this report. So now I'd like to share with you my own approach. And as a summary of the part 1, my philosophy is to be much more specific and detailed in regard to the way we approach TwoSwear cases. There is no monotherapy. There is no systematic approach. We treatment plan every patient with a highly individual approach. And that is true not only for the clinical protocols, but also for the choice of the material. And this is what I would like to present by now. So I will use as an example a case which I treated with an interceptive treatment approach with direct composite. And I will illustrate my approach with the step-by-step protocol applied to this specific case. This patient came to us after 15 years. I treated this patient 15 years ago, but she's not my patient, and she was back because of dentin hypersensitivity on the lower back teeth, and also because she was aware of some tooth wear. That is visible, of course, on the occlusal views. It's not extreme, but you see here the flattening of the occlusal anatomy. We see some dentin exposed on the tip of the cusps. And there is a last impact, which is on the smile line. If you remember from the first part, 60% of patients who consult because of tooth wear problems consult because of the aesthetic impact of tooth wear, and among those, the most obvious is the flattening of the smile line. So we are losing the dominance and the length of central incisors, and progressively all the teeth are getting shorter, sometimes with chipping and fractures of incisal edges. So the very first step is the clinical diagnosis. We look at the teeth, possibly with help of radiographies, and we try to define what is the most likely risk factor: attrition, erosion, or combined pathologies. And if we observe erosion or combined risk factors, we might need to go through a diet analysis, pH metry, or gastroscopy if we have maybe a reflux problem. If the patient is suffering from bulimia or anorexia, then normally the diagnosis is rather obvious. So we normally approach treatment plan by looking at what happens in the anterior area. We want to know about aesthetics, and we want to know about existing anterior guidance and what needs to be improved. So we'll do some treatment planning based on, let's say, clinical observation. We can, at the later stage, also involve the lab and look at the models. But in short, we want to define which improvement have to be done in regard to the smile line and the smile in general, and also how we can improve anterior guidance. Clearly, one objective is to maintain anterior guidance, to maintain anterior teeth in contact. Anterior guidance includes also canine guidance. Why is that important? Not so much because anterior guidance and canine guidance would be a much better occlusal scheme, but if you plan to use composite, direct composite do not behave so well on the shear and tensile forces. So you want to minimize lateral forces. They're quite good in resisting compressive forces, a little bit less in regard to shear and tensile stresses, as I said. And then when we have defined the new aesthetics and an improved anterior guidance, which might be by changing a little bit the overbite and overjet, then we can look at the space which we created for posterior occlusion. And normally this works together relatively well. When you have re-established better aesthetics, improve anterior guidance and canine guidance, normally you find yourself with a certain space for reconstructing occlusal surfaces. The second step involves the laboratory. You will perform a wax-up, a full wax-up, could be analog wax-up or digital wax-up, whatever. And you will define, as I said, the new smile line and the new video. Then you need to decide if you want to reconstruct the case according to centric relationship position or maximal intercuspidation or another position. Some people like to apply let's say, gnatological concepts like going into centric relationship. Some people are happy with maximal intercuspidation. Some people prefer to find a neutral muscular position, which might be even a little bit more anterior to the MIP. There are very different concepts there, and I don't want to enter into this discussion right now. So it's up to your decision. So you see here the wax up. So the treatment plan for that specific case is to build up posterior occlusion, mainly on the lower back teeth, because this is where we have the largest amount of tissue loss. It's not extreme, it's not severe, it's moderate in this case. And we'll do some small corrections on the upper back teeth, mainly where we have signs of attrition and erosion. At the moment you increase the video, you of course need to compensate for this video augmentation by adding volume, composite volume, either on the palatal surfaces of upper front teeth, or eventually on the incisal edge of lower incisors, or both upper and lower. There are different options here. When you have defined your new smile line, your new anterior guidance, your new vertical dimension of occlusion and posterior anatomy, you still need to decide which material you want to work with. And this has something to do with the individual biomechanical tooth status. With vital teeth, I can use whatever material. If I have a cracked tooth syndrome, especially mesiodistal cracked tooth syndrome or non-vital teeth, I might prefer ceramics. I don't want to enter in details this topic, but I would just like to summarize my view on this. What is dangerous with a cracked tooth or a non-vital tooth? It is further deformation of the tooth structure that might trigger progression of the cracks, or eventually at the end, if we don't deal with this in a proper way, that will end up with endodontic complication or even vertical root fractures for non-vital teeth. So I want to get something rigid. I don't speak about a crown, but I want to get something rigid that prevents the tooth to undergo diverging movements. It's very simple. It's basic physics, and it doesn't work in a different way. Whoever pretends the opposite probably doesn't have a proper understanding of what happens. So a stiffer material will provide a better protection. Don't take me wrong. I'm not saying that composite will lead to 100% of failures, fortunately not. But the stiffer the material, the best it will block diverging forces, and that will give you some better survival rate of your restorations. So that is something very important. In regard to preparation, the case we are using as an illustration for this step-by-step protocol is composite freehand no prep. But no prep is absolutely no prep, only sandblasting, so preparing the surface of natural teeth and possibly restorations to be modified by sandblasting and for adhesion. That's it. So you see now the wax up on the left side, and me trying to copy the anatomy of the wax up with the composite directly in the mouth of the patient. And I have here this small video to illustrate clinically how it works. I have the model chair side on the cart, and then I move back and forth visually from the models to the mouse. Very, very simple, but efficient. If you have good eyes, you should be able to basically control the anatomy relatively well. You might think that it is very difficult to produce this kind of anatomy, but in fact, with some experience, also due to the fact that the amount of composite is pretty much always the same. It's usually around 1 millimeter at the second molar level and 1.5 millimeter at the first molar level, plus minus 0.5 millimeter. But it's not once 1 millimeter, another time 5 millimeters. You always need to work with pretty much the same amount of restorative material, and that makes the technique more controllable over time. You see here the right lower side, and here during the adjustment of occlusion, just a few minutes after adjusting occlusion, you see that the anatomy has not been very much impacted. And again, with experience, you can control the height, the thickness of material relatively well. But if you don't feel comfortable with this approach, don't miss the part 3 of this webinar series, because I will share with you also one case of full molding, which might be of interest for you. You see here the before situation in the middle, and just before removing the rubber dam on the right and the left side. And the beauty of this treatment approach is that it takes about an hour for the molding and the finishing. Let's add 15 minutes to place the rubber down and proceed with adhesion. Another 15 minutes for adjusting occlusion. And you need about an hour and a half to reconstruct premolars and molars, possibly canines to molars. It's a very efficient method. And now you see on the central view the situation after adjusting occlusion, and there isn't much change in the anatomy. That comes with experience, of course, but this technique is very efficient, and if you don't like it, we have the molding techniques. So this is the before and after. On the upper arch, we had just to fill up basically the palatal and a few facial lesions, erosion and attrition lesions. Here they are typically combined lesions. On the other side, on the second quadrant, I had two old PFM restorations which were still absolutely okay, so I decided not to replace them. They are absolutely functional. There is no infiltration at the margins, so we decided to keep it as it is. Now we've completed the change in the video, both on the lower and the upper arch, and I still need to compensate for the change in the vertical dimension of occlusion, because otherwise I have no contact anymore on the front teeth. So this is the last, this is the third phase. First phase was lower posterior. Second phase was upper posterior. And the third phase is the palatal, eventually inside the edges of upper front teeth. You see before the treatment and after the treatment on the right hand side. We have shaped the palatal surface, and now we have some material to protect those front teeth from additional tooth wear. You see that also some areas have been worn down, and we have some dentin exposed. So not only the composite helps to reestablish proper anterior contacts, but it also protects teeth which were worn by a combination of attrition and erosion. And now you see the same case with 5 years follow-up. The thing is that, unfortunately, the patient didn't have any compliance, didn't wear the night guard at all. But finally, the situation is quite satisfactory. There are only on the upper second molars some new areas of exposed dentin, but relatively on a small scale. And otherwise, the restoration still look in a perfectly good condition. You see now the 5-year situation in the middle and the pre-treatment situation on the right and on the left. So basically, the protective function of composite has been fully successful. We lost a little bit of the fine details of the occlusal anatomy, which I had created in my restorations, but otherwise, we have been fully successful, even though the patient was not compliant. It's a moderate attrition case, so here the direct composite option worked perfectly well. The last part of the second step is basically after reestablishing a new video, building up anterior restorations, new smile line, and anterior guidance. The very last phase, which is part of our treatment approach, is of course the night guard. So there are two ways to, of course, maintain in the best possible condition the restorations and prevent further hard tissue loss, is to protect from attrition. That's the role of the night guard, and to protect the teeth from pH, from acids. So the preventive strategy is always implemented together with the restorative strategy or the interceptive strategy in this case. We know we might not be successful. So at the end of the day, the composite might also serve as a sort of preventive measure. So the composite material or any restorative material will act as a mechanical fuse. We know it's not a perfect strategy, but sometimes composite is just good enough to maintain those cases for 7, 8 to 10 years with very little maintenance work. So that is the overall strategy. What I've been showing with the direct approach might also be implemented with CAD/CAM or indirect restorations. But as you might understand, this decision will be done according to the risk factors and the severity of tooth wear. So let's discuss in more details the options which we have. So we have seen the first one, which is the direct approach, but there are many more. And this has to do, as I said, with the amount of tooth wear. I like to use, as presented in part 1, 3 levels, 3 severity levels for tooth wear: limited, moderate, severe. That's more than enough for a strategy at the private practice. Now, which are the protocols for the anterior areas? Freehand at the incisal edge, freehand on the palatal, mainly of the upper front teeth, molding for the incisal and the palatal areas, if you like, veneers, facial, usually ceramics, but it could be also composite and on the palatal, and finally crowns. And this implies actually to use different materials. For freehand and eventually molded restorations, we use composite, and for veneers and crowns, progressively ceramics. So we have different options in regard to the clinical protocol and different options in regard to the material. And when we speak about composite, we can speak about direct composite, indirect composite, CAD/CAM composite, ceramics. Most of the time we have lithium disilicate, or for crowns, maybe also zirconia. But my view is very clear. We try to minimize, of course, the use of CAD/CAM and indirect restorations, because generally it can be done without additional tooth preparation. For posterior teeth, this is the exact same strategy. We need to choose the clinical protocol and also to implement according to the severity of the case and also the biomechanical status of the teeth. To change from composite maybe to ceramics. So we have freehand, which you have seen, molding partial, full molding, which I will demonstrate in the third part, the shell technique, indirect CAD/CAM, many options. So let's make a statement at this point. There is no monotherapy for tooth wear. You can't ignore the severity of tooth wear and the age of the patient. For many patients, going with CAD/CAM techniques or indirect techniques is not really the correct approach. The only reason to go indirect with lithium disilicate, overlays, tabletop veneers, anterior veneers, to go at the end with nearly 28 ceramic restorations, the only indication for this in probably 90% of tooth wear cases is to create a beautiful documentation. And that's what I see a lot on Facebook, on Instagram, very talented clinicians who present beautiful cases, technically wonderful, but conceptually completely wrong. And this is misleading. This is tremendously misleading the profession. You need to do a lot more with composite and a lot less with ceramics. Because with direct composite or molded composite, you can do it no prep. At the moment you switch to ceramics or CAD/CAM, apart from class 3 edge-to-edge cases, which are not so many, there are some but not so many, you can't go without significant additional preparation. And I like to make this statement very strong here, because it's really disturbing to see how much over-treatment we have when we deal with tooth wear. And this, unfortunately, only to make beautiful documentation, but that's not a reason. That's not a reason to do it. So now I would like to show you another case with 10-year follow-up to summarize again the step-by-step approach for freehand. It's a case which is part of the 60% of patients consulting for the aesthetic impact of tooth wear. Patient is disturbed by the very irregular smile line. This is typical from bruxism. Patient is having mainly wear on the front teeth with cracks. Why is it so? Because you have pretty much a deep bite, and in case of bruxism, the deep bite basically creates a very effective disclusion of parts of your teeth, so that you have normally very little tooth wear on part of your teeth unless we have some erosion pathology. So now if we look at the situation where the patient is opening her mouth, you see that we have little cracks and chipping on the lower front teeth, more visible on the upper front teeth, so you have a very irregular smile line. You see that we lost the canine guidance and we have broken inside the ledges. So this very irregular smile and the broken edges, of course, it's all but aesthetic. As I said, if you look at the path of your teeth, you don't have really any big problem. We decided to change the small amalgams. And if we look at the lower arch, we have some existing restorations, which are in still relatively good conditions, and will not have to replace those restorations, but mainly to modify them. Those restorations were not made by me, but they were done, they were not in a perfectly correct way, so I don't need to redo everything. I check the integrity of the margins. I try to assess the quality of bonding procedures, adhesive procedures, and it seems to be correct from a clinical perspective and radiographic perspective. I can proceed with just the correction of the surface. So what is the clinical situation of this case? The clinical situation, what I need to address is tooth wear in the front, minimal, nearly no tooth wear on the back teeth. But if I want to create the space to restore the front teeth and get enough material to prevent chipping and rapid wear of the composite material, I need to increase the video. Again, to confirm this peculiar functional situation or occlusal situation, when you get an overbite and when you have bruxism, in fact, the bruxism will concentrate wear in the anterior area. And there is a very strict relationship between the occlusal scheme or the occlusion scheme situation in case of attrition pathology. If it is erosive pathology or combined pathologies, you might still have different consequences of tooth wear. But if you have mainly attrition, especially bruxism, you will have a very typical wear pattern according to the occlusion scheme. And it's quite interesting actually to observe, and it brings you to understand many factors which you need to take into consideration. So now I want to create space to get not only better aesthetics, better function, but strength of the restorations. And this cannot be achieved without increasing the video. We'll define this by a wax up. Depending on the case, you might need to increase the length and the thickness of inside the ledges on the upper, maybe on the lower, maybe on both. It's not the exact same treatment approach for every case. And when you have set the new video after defining on the models your new smile line and anterior guidance, then it will give you a certain space available to restore the path of your teeth. So let's actually see how we proceed to transfer this information to the mouse. After doing the wax up, you mount again the second set of model, which is actually the original models. So make sure that the technician doesn't pour only one set of models. If you go digital, it's a little bit easier because you will, of course, keep the original models. So you have your STL files for the original models that you can print whenever you need, or you can even use it and print and enter your index. So here I demonstrate pretty much what could be done on traditional models, but we also do sometimes printed indexes, which will give us the amount of space available to reconstruct the path of your teeth. So when you go to the mouse, you have the new video as defined by the laboratory, analog or digital, whatever, and then you create your occlusal stops to stabilize the new video. So you can nearly use any composite you like, enamel shade mainly, and this normally is done the more often on the lower. For the majority of cases, this is the first option. Second option, as you will see on this case we are discussing now, we have a few stops on the upper and the lower because I had to change the amalgams, so I modified a little bit the anatomy also on the upper arch. And after setting up my new video, then I build up the composite on the front teeth with a combination most of the time of dentine and enamel. Again, keep in mind that we do not necessarily need to build up the upper and the lower. It can vary from one case to another. So now let's have a look at the specific case we're dealing with here. So the technician has rebuilt the incisal edges and the palatal surfaces. But he has also done, next to setting up the new video on the lower arch, he has also added a little bit of wax. He has actually flattened the lower smile line. But this is not probably a good idea. Why? Because I will end up with very, very thin layers of composite, and I don't want this on the incisal edges, because that might lead to chipping of my restorations or rapid wear, and this is not desired. I mentioned before the fact that we usually have pretty much similar thicknesses of composite when we increase the video. And we can say that 90 to 95% of cases will follow the dimensions presented on that slide. Second molar level, about 1 millimeter. Second molar level, about 1.5 millimeter. And then progressively, you get more space. This is due to the opening, to the rotation of the mandible. At the beginning of an opening movement, the mandible go first through a mere rotation before it starts to move along the, let's say, the movement of the condyle, mandibular condyle, on the piriform eminence will create also a down and forward movement, but this is a little bit further. So the very first part of the movement is merely opening. It means that this rotation movement creates a differential opening from the back teeth to the front teeth. So that brings you to understand one element very important. I said before, I like to get a good canine guidance and anterior guidance because composite doesn't like shear and tensile forces. So if you get a good canine guidance and anterior guidance, you will minimize the stresses which impact the integrity of the composite on the back teeth where it has the thinnest, where you have the thinnest layer of the material. So we prefer to leave the posterior teeth to be loaded in compression and reduce shear and tensile stresses. So I don't need to show you again, let's say, really the technique and the step-by-step What I did with fresh composite was to change the rather convex anatomy into the concave anatomy into a convex anatomy, so that I just create the needed video augmentation. So this is now the situation after the corrections. I only sandblasted the surface, used a multifunctional adhesive system, and just applied fresh material. Those are the X-rays showing basically the addition of material. Especially on the right-hand side, you can compare the before and after radiographs, where we can see the more opaque composite material on top of the occlusal anatomy. Now you see the final situation in the front. We have recreated the canine tips. We have aligned the incisal edges. We have recreated dominance of central incisors, so it means now they are longer than the laterals. Before they were pretty much at the same level. This is with another camera, the same perspective about the front area following our treatment. So now, of course, it looks much better. I mentioned that we have different options in regard to where we apply the composite. Sometimes we don't have so much space, so we do only one side. Relatively more often, upper only. If you have more space, you're likely to use composites both on the upper and the lower. And and I just revert, and otherwise we can do only the lower. The lower is less frequent, but I have done already a couple of cases where we corrected only the lengths on the lower side. Now this is the follow-up at 1 year. No change, which we expected. We also hope the patient has been wearing the knife guards on a regular way. This is now 2 years. No change. We still have perfect canine guidance. We don't have any visible tooth wear on the inside the edges. Now you can look at the posterior occlusion. Everything looks good. There is no change in the anatomy of our restorations. Lower side, also no change in the occlusal anatomy. So everything seems to be very stable, but of course 2 years is a relatively short period of time. This is now 5 years. There isn't much change after 5 years. Maybe we lost a little bit of length or material, composite material at the edge of the upper left central, but this is very, very little. Canine's tips are still perfectly in place and maintaining canine guidance. 7 years. We just start to see a little bit a color change between the old composite and the tooth structure. Composite has slightly changed chroma. It's a little bit darker. And now we are at 10 years follow-up. We can say that overall there is very little visible change in regard to the quality, integrity of our restorations. If we ask the patient to come into or to do a protrusive movement, you see that again there isn't much change on the upper front teeth. Maybe some tips of posterior cusps are a little bit flattened, and I had also a little degradation on the facial margin, plus some extension of the composite restoration on the lower second premolar that I would like to fix. This will be done with sandblasting and a little bit of composite. This is now the 10-year post-operative status. We did not expect major impact of tooth wear or additional loss of tooth structure on the posterior areas because it was very little tooth wear at the beginning. If we don't have any major change in the risk factors. If we have mainly attrition, a typical patient with sleep bruxism, we have recreated an efficient canine and anterior guidance, so that will continue to protect the path of your teeth and the path of your anatomy. So we ask the patient to come back with the night guard, because here we are aware of the risk factor. Again, attrition, sleep bruxism. But if you look at the night guard, you see that the night guard doesn't fit so well. It fits on the edges, but it doesn't fit on the cervical. These probably have undergone some small movements, and the night guard doesn't fit really perfectly in place. And if you look at the night guard, you see that it's pretty much intact. So discussing with the patient, he admitted that she has been wearing the night guard for a couple of months after we did the treatment, but then observing that everything was behaving well, and that we had no additional tooth wear or restorative material wear or chipping of the incisal edges, she considered that she was like healed from the parafunctions, which wasn't truly the case. So I performed some small addition of composite. So I have refreshed, if you like, I've refreshed the treatment by adding a little bit of composite on the tip of the cusps to prevent eventually exposure of natural tissues that might be again exposed to a little bit of tooth wear, and also that will protect the front teeth. We also wanted to do this time some corrections on the lower front teeth, not because of really functional or severe wear problems, but mainly for aesthetic reasons, because the incisal edges were a little bit stained. We had some reactive dentin and the patient didn't like it. So we did a slight change in the vertical dimension that has created a little space to be used for restoring the lower front teeth. So now we have done some restorations. About 1.5 millimeter, we have reconstructed the lower canine tips, because I don't know if you paid attention before, they were worn down a little bit. And after 10 years, we just had to do a little refreshing of those restorations. And that is typical from this interceptive strategy. It's very, very effective for moderate tooth wear cases and relatively young adults. Young adults means basically from 30 to 50. And I think it makes sense to try. Would we find out that this is not good enough, that we don't have a good compliance of the patient with the night guard, we don't have a good compliance of the patient with pH control, if we observe significant tooth wear throughout the observation period, that should be normally 8 to 10 years, then we might have a reason, a ground for implementing an indirect approach or restorative approach using CAD/CAM materials or indirect restorations. But until we have tried, we don't have that evidence that going straight ahead with indirect approach is the right strategy. So now you see the 10-year follow-up with one reintervention after 10 years of very stable performance of our composite restorations. So basically, when we follow up the case, we are in good control of the risk factors, no sign of degradation in wear. Usually it means sleep bruxisms. And hopefully the night guard is one of the key elements for a successful approach. But anyway, composite is certainly an ideal material. Sometimes when we are not in control of the erosion or attrition pathology, like in this case, but we'll still be successful with composite. So you see here the pre-treatment situation. I've shown this case during the part 1 briefly. I show you again some follow-up of the case. This is the post-treatment situation. Everything, no prep, freehand with composite in a moderate tooth wear situation, but here with combined pathology. Here we have signs of erosion and attrition. 6 years later, no compliance, or let's say poor compliance, both with the diet control and the night guard unfortunately. You see the additional wear, erosion mainly here, above the cervical restorations, and a little bit on the tip of upper back teeth, mainly the molars. But most of the surfaces which were protected with the composite are still having composite atop. Only few areas were basically exposed by additional wear. In 2018, what I did in 2016, I have only corrected a few spots. So, for instance, on number 16 and on the cervical lesions on the lower premolars, I have made some addition of composite, but this can be done whenever needed. And in 2018, we decided to refresh the case and adding again a little bit of composite. So the follow-up of this case is not as positive as the previous one. So we have signs of degradation and additional wear. So that means either sleep bruxism and insufficient night guard compliance, or possibly as well, because that is something which is, of course, observed, not so seldomly, awake bruxism. We might have good compliance with the night guard, but we still have tooth wear during the day, or of course, erosion as well that might worsen the situation. But in any case, maybe even if the composite is not perfect in those conditions, but it's still fulfilling its role of protecting tooth structure and avoiding additional tooth preparation. I don't like the concept to treat tooth wear by removing more tissue. I think this is not, from a conceptual standpoint, it's not really a satisfactory approach. So a very last remark regarding the clinical approach for the direct technique. You need some reference points, and those reference points are the occlusal groove and the contact points and the marginal ridges. If you have tooth wear, but if the proximal contacts are maintained, if the central groove is still visible, that will help you to create the right anatomy, to place the cusps in a proper way, whether you use a direct technique or freehand or molded. You need some reference points to guide the sculpting, the molding of the composite, or to stabilize the index. And that will make the technique relatively easy. So in this case, the freehand approach is feasible, is efficient for limited to moderate tooth wear cases. Moderate cases are usually restored often with a molding technique, and severe cases are normally restored with another approach, whether CAD/CAM or indirect. But that will be the topic of the part 3 of this program. So this is coming in the part 3. I'll be talking about indirect and hybrid treatment strategies. I might focus even more on the hybrid treatment strategy, because I think this is a very effective protocol. So see you soon for the part 3. Thank you very much for listening to this presentation. So thank you in advance, Alexander, for your translation.
We are on air.
Okay. So we are waiting for the first question. Here it comes. Welcome to the Q&A session for this second part of the webinar series on tooth wear. So good evening, George. The question of George is how do we find out that the added wax up in the stone model is enough, and at the moment of transferring this to the index, The patient mouth won't feel it bulkier. Well, this is not only one question. Thank you, George, for your question. In regard to the amount of wax, provided you give the right instructions to your lab technician, and that you have defined a precise anterior scheme, because as you know now, we start first by evaluating what needs to be improved in regard to anterior function and anterior aesthetics. And we have some clear criteria for that. Aesthetic criteria are very well established. And in regard to function, we try to maintain anterior contacts, get still some overbite and normal overjet. We don't want to end up into an open bite. We don't want to leave a very important deep bite. We try to create the best possible anterior relationship, and that will give us a clear scheme, a clear project for the anterior aesthetics and anterior guidance. Then from there, what we add on pathiotes will normally be pretty much the ideal. If we would like to add more material on the pathiotes, then we lose the optimal situation we have created for the anterior function and anterior aesthetics. So this is something we cannot do. So that's why we don't really have any problem. Now, when it comes to patients' adaptation, we have some reference in regard to the maximum opening, the vertical dimension of occlusion, that can happen with nearly 100% adaptation. And this is up to 5 millimeters on the anterior teeth, which is already a lot because we rarely augment up to 5 millimeters. So this is a limit, a theoretical limit, but the limit is often below this 5 millimeter threshold, because again, if you open up too much, you will lose anterior contacts, so you will lose anterior guidance, and you might also aesthetically not get the desired situation. So it means you will never find yourself with too much volume. In principle, you should not. And the patient should adapt to this change. To be honest, I have never seen up to now a patient who didn't adapt. They feel, of course, they feel the change. They report a different sensation. Their function is a little bit different. The contacts are different. The anatomy of the teeth, which was very flat, is becoming more natural. So they will regain mastication efficiency. But I have never seen up to now someone who was not adapting. It takes a couple of days for certain people, maybe a couple of weeks for others. What I'm saying couple of weeks is maybe 2, maximum 3 weeks, never more than that. So far, I'm maybe lucky. It never happened that a patient did not adapt. They adapt by immediate muscle reprogrammation. We have what we call neuroplasticity. The cortex, which is in charge of controlling muscle function, is quite efficient, fortunately, to adapt. There are very few patients who are called occlusal hypervigilant patients. They have an hypervigilance for occlusal changes. Those might need a little bit more time to adapt. But again, I've never seen one who did not adapt within the range of vertical dimension augmentation, which we spoke about. So sorry for the long reply, Georgia, but I think that was a very important question to be replied comprehensively. Now, question from Christina. Good evening, Christina. Her question is the following. After restoration of occlusal wear, and if you suspect poor compliance from patient, would you recommend Botox treatment or for bruxism? Thank you. I would say this is something that needs to be eventually evaluated already at the time of treatment planning. When you see that the muscles, especially the masseter, are hyperdeveloped, that could be combined to really severe attrition. You're right. We can do something which is, of course, very simple, which is to get the night guard, but the night guard will probably not stop, of course, the parafunctional forces and the parafunctions, the bruxism or the clenching. And there is today this option to use the buttocks. As we all know, the buttocks will need to be repeated quite a number of times until eventually the muscles volume will get reduced. From there, anyway, we might need to use a night guard. So I wouldn't necessarily exclude the night guard, but you're right to suggest the fact that if we can't get the compliance of the patient, the buttocks is an option. There is still a little bit of an open point in regard to the potential long-term side effects of using buttocks for extended period of time. I don't have personally, I didn't search in the literature which are the possible long-term effects of using buttocks. It's quite unlikely that even if you use buttocks for a certain time and you get a reduction of muscle volume, it's quite unlikely that the parafunctions will disappear. There is no rationale which would support the fact that buttocks will not only be, let's say, or will be active on or reducing the parafunctions, but not necessarily curing the parafunctions. By today, we don't know any cure for parafunctions. Anything we can do with substances like buttocks or with local interventions that would basically stop the patient to broads, unfortunately. So thank you very much for your question, Christina. Good evening, Ralu. The question of Ralu is the following. Is there any other method in appreciating the amount of composite on the occlusal area rather than the visual one in relation to freehand technique? Then we are just a little bit ahead with the program. I will present in the next webinar, I will present the full molding technique. I mentioned different options, and we have actually several options depending on the amount of tooth wear. I trust you understood that the freehand bonding is probably the first intervention that we can use. If you have limited to moderate tooth wear, it's rather easy to do it freehand. And it's very efficient. You don't have any problem with excesses. That is unfortunately happening with molding techniques. But if you have a little bit more complex situation, then the next techniques are partial molding. It means we do only the molding of the facial cusps and lingual cusps, and we just freehand the central part. We have the full molding that I will present in the next webinar. It will be a video and a step-by-step case to illustrate this technique. Then we have the molding technique, but made in the lab. So the technician will mold or use the wax up to do a molding technique, but on the models, and it will deliver like small composite overlays. They are normally heat cured, so that it gives a little bit of extra mechanical properties to the composite. And then, of course, we have either CAD-CAM or indirect. That's basically CAD-CAM composite or CAD-CAM lithium disilicate, or a couple of alternative materials also. But the most frequent one which we use is lithium disilicate. It's bondable and it has relatively good strength, or pressed ceramics. So we have in fact a dynamic approach to tooth wear, which is based on the severity and also somehow based on your clinical experience with handling freehand composites. But if you feel a little bit uncomfortable with the freehand approach, one of the molding techniques might be for you. And well, you will need a few minutes to clean the excesses on each restoration or on each tooth, but it's a highly controllable technique. And they are, of course, based on the partial and the full molding technique. There are some alternative sort of mix in between those techniques which are available. So thank you for your question, Ralu. It was a very interesting question to reply. Good evening, Yvonne. The question of Yvonne is, when do you freehand technique composites? How can you control the 0.5 to 2 millimeters of composite? Will following the central grooves and the margins be enough? How can you control the new video? Thank you very much. I'm quite happy to see that you are challenged a little bit in your understanding and what you know about the use of freehand technique. And it is true that before you ever tried it, it seems to be a big challenge. To go freehand and to reconstruct the full occlusion freehand seems to be a nearly impossible challenge. One piece of advice that I haven't mentioned during the presentation is that maybe at the very beginning you can use a probe, a periodontal probe, to assess the amount of composite. I would really say it depends on how much composite you probably do daily. If you do a lot of direct bonding for small, medium-sized cavities, either on the back teeth or on the front teeth, I'm sure that you might have a sort of sensation about what is a 0.5 millimeter or what is 2 millimeters or 1.5 millimeter, whatever. The idea is that when we sculpt, first, we don't try to do a sculpture which is very, very deep, because that might eventually bring us to build up cusps which are far too high. So normally, if we start with a rather flat surface, we'll recreate volume and anatomy, but it's a little bit easier to control if you apply relatively thin layers. If we will go for 3 or 4 or 5 millimeters, that will be nearly impossible to control. But if you stay within relatively thin layers, 0.5, normally we rarely go below 1 millimeter, let's say 1 millimeter at the level of second molars, and increasing slowly 1.5, 2, 2.5, normally up to 3 millimeters, 2.5, 3 millimeters on the canines. Don't forget that we need also to add very often on the antagonist side. I have got the feedback of many colleagues who tried this, and that has confirmed my first experience. This is not so complicated. It looks very complicated, but again, if you're unsure, look at the molding techniques, and that might give you some confidence to start with those treatments, and then you can eventually do some cases or some teeth with a direct freehand approach. But remember something very, very important. You don't have many alternatives here. If you think about going indirect or CAD/CAM, there is no prep. It is, for the large majority of cases, impossible. You can't do it. You need to prep, unless you change completely your occlusion, which we don't really, for which we don't have true evidence. We try normally to stay around the MIP, maximal intercuspidation, maybe a little bit forward, maybe a little bit more distal, but we don't do a major repositioning of the MIP in a more anterior position, with exception of edge-to-edge cases, class 3 tendency, where we might be able, by increasing the video, to recapture a better overbite overjet. But class 3 cases are probably the only cases where we could do a significant video opening and maintaining a proper anterior or recreating a better anterior relationship and maintaining pretty much the MIP or being close to the MIP, which is probably the safest by today the safest approach. But I would really say don't get too much worried if the anatomy is not super refined. The aim is to help the patients, to protect the teeth, to undergo further wear. And then also back to the first question from Georgia, if we realize that we have, the question of Christina, if we don't have enough compliance or if the severity of parafunctions is too high, very often a combination of both, then we have the right information to suggest the patient to undergo a more complex rehabilitation, more invasive, and much more expensive. But I would not consider that for moderate tooth wear, going indirect or CAD/CAM is the right thing to go to start with. Thank you very much, Yvonne, for your question. Question from Jorge. I trust same Jorge as the one of the first question. Jorge is asking if there is a way to illustrate in a video explanation for the next webinar how to make a right occlusal adjustment after the full rehab. I don't have a video, honestly. I haven't made a video for that. I hope you have seen on this webinar, you have seen the contact. We try normally to adjust occlusion mainly on the cusps, as little as possible on the fossas, and that's why it is important to get the anatomy right. And if you do that with us wax up, it's going to be very difficult because you need to see on the wax up where the fossas should be located, where the contact should be located, so that you know pretty much how to develop your anatomy. But most of the corrections are being done on the cusps. And something that I have not mentioned during the webinar is that we normally go for three different occlusal equilibration steps. The first one is at completion of the restorations. But patients have been, of course, with the mass open for quite some time. It might be a little bit of stiffness in the muscles. And we try to manipulate the patient, but we know that it might not be the very best moment to do the final equilibration. So we try to get minimum number of contacts left and right, and then I will see the patient a week later. We only do a check, and this, of course, after finishing the posterior restorations, or let's say after finishing the rehabilitation, doing a second equilibration. When the patient is more relaxed, we can eventually even try, if we believe it is appropriate, try to place the patient in centric relationship, even though I'm less and less convinced that this relationship serves any purpose. There is more and more controversy about the centric relationship. And in any case with composite, if you get some interference in certain positions that you cannot reproduce during your equilibration, the big advantage of the composite is that it will be self-adapting. You will get little wear facets developing where you have slight excess of contact. So that's fantastic. It's a wonderful material for that. It's up to a certain point self-equilibrating. You also have some micro movements the teeth can undergo that will contribute to a little bit of adaptation. And to come back to my treatment agenda, I have a third session, which is the session during which I will take the impressions for the night guard, during which I will do the last fine-tuning of the equilibration. So again, one post-treatment equilibration, then 1 week after finishing the treatment, a second equilibration, only equilibration, and then the last one, the last little corrections at the time we do the impressions for the night guard. I normally always respect 2 weeks before completion of the treatment and making impressions records for the night guard. Okay, I hope that was providing some insight about our approach. So thank you, Georgia, for your question. Now, next question is from Fanas. Good evening, Fanas. Question here is, can you please show a video next time how you would register a centric relationship in a patient to increase the OVD? Luchazig, we don't want to use the CRP. So I will not show you. Why would you try to do so? The sort of semi-consensus, because if you speak to prosthodontists, they will probably still disagree with that. But I think pretty much about prosthodontists, nearly everyone is in agreement today that the CRP was a relationship that we had to record. At the time, patients were either partially edentulous or fully edentulous because we had no other reference. And of course, that became sort of a habit. Now, the fact that this occlusal position will bring any advantage, we have never been able to present any evidence that centric relationship in dentated patients has any advantage over MIP. On the contrary, it's not necessarily a neutral position from a muscular standpoint. Even MIP might be more anatomical, but not muscular neutral position. So now there are more and more people being interested to find not the CRP, which is an anatomical relationship, not the MIP, which is a dental contact, somehow dental relationship, but more the neutral muscular relationship, in order to find even a better relationship if we need to restore. If you don't restore, of course, there isn't much point to find a different position than the MIP. But so first of all, the occlusal scheme, the CRP occlusal position doesn't have any rationale, first of all, or scientific rationale by today. Second reason, more posterior you move the mandible, more discrepancy you create on the sagittal and the transversal plane. You can take models. You open up and you move the mandible a little bit backwards, and you will see that you create discrepancy, occlusal discrepancy. So more posterior you move the mandible, more problems you have to create a proper anatomy and inter-arch relationship. So in principle, all but the CRP. MIP possibly more anterior if the neutral muscular position can be found in a more anterior position. They are different. I'm personally not yet supporting with no restriction the use of a more anterior position, because here as well we are lacking a little bit of evidence by today. A lot of people like this position because it facilitates the treatment, but it is somehow a little bit of experimental from a scientific standpoint, a little bit experimental by today. We are doing cases now, but I don't have enough long-term follow-up or enough follow-up to be able to make any statement here. So I would say, to make a long story short, MIP certainly not more posterior, and then we'll observe the restorations. We'll see if some wear facets develop, if the patient report any discomfort or anything. We can try to move the patient if the muscle seems to be relaxed enough. I like always to check a little bit a sort of centric relationship, because anyway there is no real true centric relationship. It changes from one day to another. It changes depending on the technique which we use. We don't even want anymore to force the mandible to go in a very posterior position. Again, it's so controversial that I think we should probably not try to find it at all. So hopefully that was replying your question in a comprehensive way, Fanas. Thank you very much. Now, question from Dirk. Is the injection technique with flowable also an option? Do you use it at all? No. I think that the rationale, of course, is to simplify things. I will see, from a conceptual standpoint, I will see an indication as a sort of a long-term mock-up, if you like, sort of a trial phase. I think this is probably the real indication of using flowable. Flowable materials are not so bad. I don't want to say that flowable materials, there are differences, of course, in between different companies. Some flowables have been improved. They are having better mechanical properties, but anyway, they will never match the best restorative composites we have. This is one thing. The second thing is that a flow consistency will tend to bring composites everywhere. At least there is no way to avoid it. You will create more excesses, and I don't even see any rationale to go. You can mold a restorative composite, a heated composite, and I don't see any reason to use a weaker material to even possibly have more problems to remove excesses instead of using a good restorative material, which is easily molded when it is heated up. It's easy to mold. Excesses are much easier to remove. You will save time. So at the end, honestly, I don't see any rationale at all to use flow. And even if you want to go with, really with a sort of short-term trial in regard to your new video, go with a tray, a night guard. Go with a removable appliance. But at the moment you bond something on the teeth, don't use this injection molding technique. I don't think it follows any sound rationale, honestly. Thank you, Dirk, for your question. Question now from Maya. Good evening, Maya. Thank you for your presentation. My question: what sort of polishing do you use? Discs, possible brand, Arkansas, enhanced gloss. Thank you again. Well, I'm not very strict on the choice of finishing and polishing instruments. I would be much stricter, for instance, on the choice of the adhesive material. I might be a little bit stricter sometimes on the choice of the composite system, but I think polishing systems are many, and many are excellent. But I will just share with you my choice. My choice is for the discs, the Opti discs from Kerr. They're very similar to the Popan XT from 3M, but the mandrel is a little advantage. It is flat on the top, and the ring holding the disc on the mandrel is plastic. So you don't have this problem of black traces which are left by the mandrel or the ring or the disc itself from the Popan XT. But the Popan XT, otherwise, they work fantastically well. I use otherwise fine diamonds, mostly the flame when it comes to building up posterior occlusion. And then you can use a polishing paste, but normally I use really on the margins a silicone polisher. You can even simplify it to a pre-polisher, but this I do after rebonding. The rebonding, you have seen that the restoration, they look very smooth, very shiny, very beautiful. When you have finished to remove excesses or adjusted your margins with the discs and the fine diamonds, I forgot to mention maybe for the occlusion, but that's coming a little bit later. We use also football diamonds or diamond burrs to adjust occlusion. But when I'm normally finished with the margins, and the excesses in case of, well, that's more for the molding technique normally. I will use a self-etch two-step adhesive system. The one that I use is the Clearfield SE Bond or something similar. I use the primer to clean everything. It's serving as a cleanser, blow air, and then I use the bonding for surface sealing. So that will seal all the little defects around the margins. There are always little defects here and there. And also will leave very little, but just what we need to get the surface getting very shiny. And then we just polish with the brush. We light cure, of course, under glycerin gel. And we then just go finally with the brush. For this type of application, we do a sort of glazing. When you do the fine sculpting, you cannot polish the entire anatomy. This is impossible. So you need to do a surface glazing in this case. We don't do that for anterior restorations, but for large posterior occlusions, occlusal restorations, rebuilding occlusion, that's the best method. Okay, so thank you, Maria. Now a question from Christina, maybe Christina again. For direct restoration on path of your teeth, do you use Inspiro composite as well, or some different brands? Thank you. Inspiro is a highly filled material. It's a new type of nanohybrid. It's not in a homogeneous nanohybrid like all the first generation products. It's a new generation of nanohybrids with homogeneous distribution of nanofiller in the matrix. That's why, by the way, it has a little bit firmer consistency because this technology makes it a little bit firmer. I love this firm consistency myself because it's a key advantage when it comes to molding the anatomy. That's the one that I'm using for building up posterior occlusion. But I would say any good hybrid will work. We have, but normally the recommended choice is something either from nanohybrids, even though the first generation of nanohybrids were slightly inferior mechanically to microhybrids. I would not say classical or the old generation of hybrids, but modern microhybrids, what we also call mini-filled composites. But it should be a technology that has been developed for use on path of your teeth. And there is a large choice. I would just avoid spherical composites because spherical technologies, normally they are really specifically developed for anterior applications. They have a nicer gloss. The handling is very nice too, but especially enamels or incisional shades, they have inferior mechanical properties. But we normally use an enamel-like material or transparent material. If we think about classical system, the tetric, the old tetric material works very well, or the Herculite. They are very old materials from the microhybrid generation. That's what I've been using also for many years. It's working beautifully well. You don't need just. There is no specific material developed for building up posterior occlusion. We need to use a posterior composite. Thank you very much. We have another question from Georgia. Can it be done, the equilibration as the one that did on the composite to the ceramic one as well? I would say yes and no. Let me explain, George. In fact, when we do ceramic restorations, which means we go indirect or CAD/CAM, we expect the anatomy and the occlusion to be very finely defined on the models or on the computer if we go CAD/CAM. We don't expect to get in the mouse and to have to proceed into any major equilibration. We all know that the ultimate articulator, so to speak, is the patient's mouse. So we'll never get, or let's say, we'll never get to that level of perfection and precision with CAD/CAM technology or even analog classical technology, even if you use a fully adaptable articulator. A little bit of intraoral equilibration will be needed, but it's really fine-tuning, reducing a little bit the pressure here and there. It's a different type of work when you consider equilibration of a freehand case. If you go with the full molding technique, if you really apply it in a perfect way, and if the wax up was done in a perfect way, the amount of corrections is much less. But if you think about the case that I've used to demonstrate the step-by-step protocol, okay? If you remember this lady where I built up the whole lower occlusion between the anatomy as we could see it on the rubber dam before I started the equilibration and the situation after I completed the equilibration, there isn't any big change. But that is the whole discussion we had before about using a freehand versus a molded versus eventually an indirect technique. But by principle, we'll need to do a little bit more equilibration. We'll not get crazy about trying to create tripodic contact. This is something from the past. This doesn't exist in dentistry, this anymore. This gnatological concept do not exist. What I might pay attention to is what I said at the beginning. We want to maintain anterior guidance. I like Canon guidance, not because there is any evidence that Canon guidance might be better than group guidance or might be better than bilateral occlusion, but in fact, guided occlusion, but in fact, the disclusion of pathological restorations by anterior contacts and canines will reduce shear and tensile stresses. The composite, when it works under compression, is a relatively strong material. It really behaves in a good way. When you add shear or tensile stresses in relatively thin layers, this is where the material will suffer a little more. So that's why there are a couple of rules. We try to make the anatomy, of course, not extremely deep, because again, if you want to do that, you will need either to prep the teeth or to increase the video further, this 5 millimeter threshold. So you never find yourself in a situation to do an extremely steep anatomy. So you have a relatively flat anatomy because it's given by the nature of treating two-square cases. And we'll try to assume a good canine guidance and anterior guidance so that we don't have too much lateral forces on the cusp and on the composite where you have thinner layers. So those are relatively simple principles. We simplify a little bit, of course, the scheme, the occlusal or the contact scheme which we have at the level of each tooth. This tripodic contact of gnatology, this very detailed anatomy of the occlusal surface to comply with gnatological principles. That is honestly, the whole literature is basically not as, well, I don't want to be disrespectful toward those who might still believe or apply those principles, but to say the things in a simple way, there is no evidence by today to support gnatology anymore. So that is that's working. That's working in a way. When you have nothing left, of course, you give yourself some principles to restore the case, but it's more when you start from nothing. Now we don't start from nothing. We have already teeth. They're worn down, but the nature of the treatment is implying certain limitations in terms of the kind of occlusal concept we can apply. Sorry to be a little bit comprehensive here, but I think they are nice discussion that we can have at the end of the program. It's a little bit more difficult to discuss in the middle of the presentation. So thank you, George, again for your interest and your questions about occlusion. Now, a question from Yvonne. Again, can you refresh the type of occlusal guards you recommend? Will it be according to the sensitive severity of bruxism or the type of restorations you have done, direct or hybrid, soft night guards, hard night guards, the thin ones for day bruxism? But Yvonne, you have somehow provided already some answers in your question. Thank you, because that's a good question. Unfortunately, there are so many aspects. As you understood, over 3 hours, it is impossible to touch any single aspects of tooth wear. And for instance, night guards. I mentioned night guard many times, but I didn't have time to give you so much information about that. So, for sure, in principle, the night guard thickness, not necessarily the material, but the night guard thickness has something to do with the severity of bruxism. We can also decide whether we use a hard tray or eventually a hybrid tray. We have now some wonderful materials. You might know the company Ercodent in Germany. They have a material called Ercolock. You have a hard shell and a soft material inside. It's very comfortable. Some people love it, but some people don't necessarily like to have something on which they can chew. So some people don't like the fact it is soft, not soft on the outside, but soft on the inside. So for the majority of patients, I would say our standard material is a hard plastic called Ercodur. That's the one system which we use from Ercodent. It's a heat-formed technology, and it's 1.5 millimeter. It's not too rigid. It's pretty much accepted by the majority of patients. We might start with the thinner one at the very beginning if we feel, or if the patient reports a little bit of problems to adapt to it. We can use something a little bit thinner for a short period of time. This material could possibly be used for day guard. The 1 millimeter hard plastic is pretty much equivalent to Invisalign trays. So in fact, when you see the number of patients wearing Invisalign or something similar, and the majority, if they want to straighten their teeth, very few are having really any major problem to adapt themselves to the trays. So in principle, there would be no reason why the patients don't want to wear the day guard. The reality is that unfortunately, I have seen relatively few patients who accepted the idea to wear a day guard. But if we want to give the chance to the patient to, for those who have obvious awake parafunctions, awake bruxism, then I will use a thinner one for the day, maybe lower arch. It's less visible. Depends on the age of the patient, because when patients are aging, they show more and more the lower teeth and a little bit less the upper teeth. So possibly we could also do it on the upper arch for a day guard. Otherwise, if we have some restorations which we believe might be a little bit more fragile, or if you have a lot more restorations on one side rather than the other, that might be eventually the side with the largest number of restorations or the more fragile restorations, which will receive the night guard. In terms of absorbing stresses, that should work the same, whether it is upper arch or lower arch. So thank you very much, Yvonne. Question from Sheila. Good evening, Sheila. Thank you for your presentation. I appreciate your thanks. As I said before, it is always a pleasure to watch your presentation. Thank you again. what do you think about the use of silicone key to the hands, to the freehand composite? I know you don't use that, but for the beginner, may it help or not? The silicone key to do the hand-free composite. No, on the contrary, Shayla, I love the molding technique. This is what I call the molding technique. So we actually use a hard tray to stabilize, to get something rigid, stable. We line this thick tray with a soft silicone, translucent silicone. The Memazine, that's the technique I will present next week. The next webinar. And it's absolutely a feasible technique. What I'm a little bit less, not enthusiastic because it's very simple, but it's a little bit less precise, is to go with single index 2s by 2s. That is one of the alternatives because there are many alternatives. I prefer personally either to go facial and lingual to build up all the cusps so that I have a precise control of the vertical dimension and I have a little bit of freehand build up to do in the middle. And if I have a good wax up, I think it is safer because you have less risk to displace the tray, as you will see next time. And that is a great technique. Honestly, this is a great technique. Thank you, Shela, for your question. Question from Ralu again. Gudiva, hello again. Can it be done, the equilibration as the one did on the composite to the ceramic one as well? Any alternative to sandblasting? Okay, maybe I missed something. As the one did on the composite to the ceramic one. Well, I think for the difference between equilibrating ceramic and composite restorations, I think this was already replied. Any alternative to sandblasting? Yes. You need to use fine diamonds on enamel or discs. And for dentin, I will use preparation diamonds, a little bit coarser grit, 80 to 100, let's say 80 to 120 microns. Because we want to activate dentin, we want to take away the hypersclerotic dentin, and we also want to use the hypermineralized enamel, the aprismatic enamel, sorry. So we like to take away, even if the tooth is clean, it's not, well, normally we hope that at the time we do this kind of treatment, the patient has been seen by the hygienist before, or we do the cleaning by ourselves, but we have at the level of enamel, apart maybe just the contacts, but the restorations will always go somewhere around the existing tooth structure. So you might get a prismatic enamel, which is more difficult to bond to, and hypersclerotic dentin, which is also more difficult to bond to. So you need to activate those surfaces. It doesn't mean prepping. You go with the discs or with fine diamonds on the enamel and just you roughen the dentin surfaces where dentin is being exposed. You roughen with preparation diamonds, and then you are all set to start with your adhesion. Thank you, Radu. Last question from Olga. How do you glaze which material? Thank you, Olga, for your question. So I mentioned one product, which is the one that I use personally. It is a two-step etch and rinse. You might certainly have easy access to that material because it's one of the golden standards in terms of in the field of adhesives. It's the Clearfill Esi-Bond from it's a Japanese product from Curare. It's a very well-known material. It's not supposed to be used for that particular indication, but I don't know how it happened, but probably not more than 15 years ago. I had the idea to use this material. And again, the self-etching primer is being used as a cleanser. And we use the bonding of the Clearfill Esi-Bond as a surface sealer. Alternative to this, you can just etch. Why do we need to clean? We need to clean because as soon as you went with some finishing, you will create some smear. So your micro defects, even the surface has some smear. And we need to clear, we need to remove this smear from the occlusal surface, from the margins, from any place which we want to seal. So alternative to the product and the technique which I mentioned is etching the surface with phosphoric acid, regular phosphoric acid, 37% in general. You don't need to etch for a very long time, 10, 15 seconds, it's enough just for cleaning. And then you can use either a hydrophobic bonding agent, anyone which you might use, or a surface sealer. You have many surface sealers. They are hydrophobic resins. Normally, many of them are based on BCMA and TEGMA with a little bit of microfiller. You have OptiGlaze, you have Anasil, you have Discover, but I don't know, I don't have all the product names in mind right now. You can use former simple hydrophobic adhesive systems like Iliobond. The only thing, it must be a hydrophobic material. Don't go with the universal adhesive. It's too much hydrophilic. It's more likely to get stained. And it might create also a very thin layer. You want something a little bit thicker. So you want something a little bit more viscous than a universal adhesive. Of course, the universal adhesive, as it is also a self-etching product, or at least it is slightly acidic enough to clean at the same time. That might look easier, but I'm not sure it will do the purpose. So use a surface sealer. If you're not sure, ask your regular dental dealer. I'm sure they will find, depending where you are, of course, product names might vary, and the access to certain products might be different. But I think this is something which is still very common in the field of restorative dentistry. So I'm nearly sure that either with just a hydrophobic bonding from a more classical adhesive system, two-step etch, three-step etch and rinse, or two-step self-etch, they normally have the appropriate bonding material. There is only one exception, maybe, which is one material that I love, that I use very much, and that's normally my adhesive that I use for all those cases, which is the Optimum FL from Kerr. But the bonding is really filled with a little bit coarser filler. And that's maybe not the smoothest material to be used for rebonding. So better to use something that is filled with a little bit of microfiller or nanofiller rather than with a conventional glass filler, which is a little bit rougher. So, Olga, with your question, I think we are finishing this Q&A session for this second webinar on toothware. The content of the last webinar will be about molding technique and direct-indirect combination, what I call hybrid therapy. And I think this will be a very interesting additional information to just the classical interceptive treatment with Composite. Thank you again very much for listening to this webinar. Thank you for all your interesting questions. Thank you for your time, and see you soon for the third webinar. And thank you once again to Otixident team for putting together this program for you, and also to Alexander, our translator, who did a fantastic job. Thank you again. Goodbye.